We'll start the fifth session of today by inviting Dr. Doha Abdelhamid, Swiss Canal University, to present over 10 minutes, please, assessment of platelet glycoprotein 2B3A gene polymorphism as a potential risk factor in ischemic stroke patients.
Good evening, everyone. Mr. and Mrs. Chairman, honorable professors and colleagues, it's a pleasure to be here today, and I'd like to start by expressing a great appreciation to the Egyptian Society of Hematology and Research for the fruitful efforts regarding all aspects of hematology, hoping for a successful 16th conference. So in the following 10 minutes, I'm delighted to present a study about assessment of platelet glycoprotein GP2B3A gene polymorphism as a potential risk factor on ischemic stroke patients, and it was also accepted in the last ISTH conference. Ischemic cerebrovascular stroke has been named as one of the leading causes of morbidity and mortality worldwide. It is considered a complex multifactorial disorder and is thought to result from an interaction between a person's genetic background and various environmental factors. According to recent estimates, the overall prevalence rate of stroke in Egypt is high, with a crude prevalence rate of 960 per 100,000 inhabitants. Platelets play a fundamental role in atherogenesis, thrombosis, and development of ischemic complications. Numerous molecules and biological mechanisms were found to be associated with ischemic cerebrovascular stroke, with platelets being particularly contributive to its pathogenesis. Recent data indicate considerable variability in platelet phenotype, which accounts for differences in platelet surface receptor function, count, and reactivity. This diagram here shows the platelets and the role in arterial thrombosis. The platelet glycoprotein GP2B3A is a heterodimeric glycoprotein complex found on the platelet surface and in the platelet alpha granules. It is the most abundant platelet glycoprotein. Platelet GP2B3A plays an indispensable role in hemostasis and thrombosis. Consequently, inherited qualitative and quantitative abnormalities in the GP2B3A reduces platelet aggregation, resulting in the bleeding disorder Glanzmann thrombocythemia, or conversely, arterial thrombosis. This is a schematic drawing of the typical integrin dimer and the platelet glycoprotein GP2B3A receptor. Platelet glycoprotein GP2B3A is composed of two subunits, the GP2B subunit and the GP3A subunit, coded by the closely linked individual genes. A point mutation has been identified in the GP3A gene at the nucleotide 1565 of the gene, a substitution of cytosine to thymine, resulting in a change in the 33rd position of the amino acid chain. The single nucleotide polymorphism is responsible for the platelet antigen called the wild type, the platelet A1, and the mutant type, the platelet A2, variant representing the mutated allele. Platelet GP2B3A can transmit information bidirectionally across the platelet plasma membrane. Upon platelet activation, inside-out signaling pathways increase the affinity of platelet GP2B3A for fibrinogen and other ligands, allowing for rapid platelet aggregation to prevent excess bleeding. Ligand binding by integrins is enabled by conversion between low and high affinity states through integrin activation. The transduction of activation messages from upstream receptors such as glycoprotein 6 culminates in integrin activation, the inside-out signaling process. Ligand binding and integrin clustering subsequently stimulate outside-in signaling, which initiates and amplifies a range of cellular events as platelet shape change, granule secretion, thrombus consolidation, and clot retraction. This is a diagram for the outside-in signaling and activation, and this one is that for the inside-out signaling and activation. The inhibitors of platelet GP2B3A receptors are likely to be the first anti-integrins to be used widely, and they should lead to the development of other clinically useful agents directed against cellular adhesion molecules. Monoclonal antibodies, natural products, and small peptides were all shown to inhibit the GP2B3A-dependent platelet aggregation. These inhibitors became the forerunners of antagonists that went through the preclinical testing and into large patient trials to treat acute coronary syndromes. So our study was aimed at assessing the beta subunit of the platelet glycoprotein GP3A polymorphism as a genetic risk factor for ischemic cerebrovascular stroke patients in Suez Canal area to determine the possibility of using it among the screening tests for ischemic cerebrovascular stroke in high-risk population. So this study was a case control study that included stroke patient group and control group. The stroke patient group contained 50 cerebrovascular ischemic stroke adult male and female patients, and the control group included the 50 age and sex match apparently healthy individuals. The diagnosis was based on the medical history, the neurological examination, computed tomography scan, and/or magnetic resonance imaging to distinguish brain infarction from intracranial hemorrhage as the cause of stroke. Data were collected by an interview questionnaire, general clinical examination and neurological examination were performed, and laboratory investigations. The studied individuals of both groups were subjected to the following investigations: the hematological assessment, the biochemical assessment, and the molecular assessment that included the following: DNA extraction and purification, and platelet glycoprotein GP3A genotyping. DNA extraction and purification was carried out using microcentrifugation technique, and platelet glycoprotein GP3A gene genotyping was carried out using polymerase chain reaction restriction fragment length polymorphism technique. After DNA amplification carried out by the PCR technique, the digestion by the MSP1 endonuclease restriction enzyme of the PCR amplified product, followed by the agarose gel electrophoresis separation and identification. This picture shows the agarose gel electrophoresis of the amplified PCR product before the restriction enzyme. And this is a picture to illustrate the different bands that we expected to find. As shown here, the lanes 1, 3, and 5 are the amplified PCR product before applying the restriction enzyme. And they appear as a single band at the 266 base pairs. The homozygote normal appears as a single band in the 221 base pair, the second lane. And the homozygote abnormal is the lowermost, appears shown here in lane 6 at the 177 base pairs, and heterozygote would show us two bands of the 221 and the 177. This is a picture of two plates of electrophoresis of our actual products. So lane 2 here shows the amplified PCR product, 3 and 5 and 7 heterozygote, 4 is a homozygote normal, and 6 is a homozygote normal. So we found out the following. Results of the study population included the following data: demographic, clinical, laboratory, and traditional risk factors, pattern of the platelet glycoprotein GP3A polymorphism of the study population, and statistical analysis. For the sake of time, we're going straight to the genotype profile, and this table here shows the genotypic profile of stroke patients group and the control group. And interestingly, we found out that 5 stroke patients were homozygote for the abnormal gene or the mutant gene, as compared to only 1 in the control group. 16 were heterozygote as compared to only 8 in the control group, and the rest were normal. And those results were clinically significant, statistically significant by the Fisher's exact test. This is another bar chart that shows that there is a statistically significant difference between the study groups and the control group. So this table here represents a binary logistic regression model with constant presence of the GP3A polymorphism as a risk factor in each model. It shows that the role of the GP3A phenotype as a risk factor of the development of stroke, if present alone, is maximized. On the other hand, it's co-present with other risk factors. The role predominates, with the role of the GP3A genetic risk factor is reduced. And this reduction is accentuated by the increasing of the number of risk factors a person possesses. The most comprehensive meta-analysis to date of the association between carriage of the GP3A allele and ischemic cerebrovascular stroke was presented by Floyd et al., and which is a study that included 20 published articles and 11,173 individuals. And they demonstrated that the carriage of the mutant allele is associated with an increased risk of ischemic cerebrovascular stroke, and the risk is almost 5 times more in homozygote individuals than others. In Singapore, Lim et al. Reported a significantly higher frequency of the platelet GP3A among Indians relative to the Chinese, but this was correlated to the higher rate of ischemic heart disease that is seen among Indians compared to the Chinese and the Malay ethnic groups. In South Africa, Nairn et al. Reported that the prevalence of the platelet GP3A polymorphism was significantly higher in the white Caucasian than both Indian and African population, all of which are consistent with our study. The GP3A polymorphism and the modulation of the platelet function. The modulation of the platelet function with subsequent potential increase of the prosthrombotic tendency was studied by many authors. One of them is Vijayan et al. Using the Chinese hamster ovary cell lines expressing GP3A allele, showed that there was a greater adhesion to the immobilized fibrinogen, a greater spreading with actin reorganization, and greater clot retraction. Finally, Todonova et al., using atomic force microscopy imaging and nano indentation with platelets immobilized on glass surface, found that carriage of the prothrombotic platelet GP3A allele showed the following: a strong modulation of the platelets nanomechanics, platelets morphology, the degree of platelet stiffness, roughness, platelet membrane elasticity, and platelet activation state, which could have an implication for the understanding of the factors that drive hemostasis and thrombosis. So based on all the previous, we concluded that genetic platelet glycoprotein GP2B3A polymorphism could be considered as a potential risk factor for ischemic cerebrovascular stroke that could predict the occurrence of ischemic cerebrovascular stroke. However, we were faced by some limitations during our study. This study included only a small number of patients who survived the acute stroke phase. Therefore, if the platelet glycoprotein polymorphism was associated with increased morbidity and mortality, the effect could be underestimated due to our mortality bias. And to wrap this all up, we strongly recommend the following. The present study is recommended to be carried out on a larger sample sizes of a younger age group of patients to reduce the effect of traditional risk factors which predominate in older individuals, and the activation of a uniform registry for ischemic cerebrovascular stroke patients among different neurological centers in Egypt to facilitate further future research study. Thank you.
شكرا دكتور ضحى على البرزنتيشن الكومبريهنسيف دي.